Hi there. I'd like to welcome you to this week's edition of on Socialist Telly of the NHS campaign information. Today we're going to be talking about the latest announced reforms to the NHS that a lot of the media have hailed as a huge success and a massive victory for the NHS. But we all know what reforms to the NHS under Tory governments, at least, are likely to mean. So I'd like you to listen to what my guests have got to say on this. I've got speaking long-term NHS campaigner and activist Sandra Ash. I'm also welcoming back Dr. Bob Gill, a GP NHS campaigner. And also I'm joined by Nicholas, who's an NHS campaigner activist, and he scrutinises NHS policy from whatever government official is putting information out, or opposition for that matter. Would any of you like to tell us a little bit of the history of reforms of the NHS over the last sort of 20 years or so? Dr. Bob, would you like to start on that, please?
Sure, thank you, Bonnie. Thanks for inviting me on. The attacks against the NHS go back decades. It hasn't just started since 2010, and they've necessarily been by stealth. So they go back to the 70s, actually, since Margaret Thatcher's government. And what happened quite early on was the breaking up of the NHS away from a collaborative ethos into more of a business-like structure. And these were done in the early 80s under what was known as the Griffiths reforms, creating a bloated management tier at the top of the NHS in order, we were told, to bring in business discipline and improve efficiency. And what they set about doing was dividing the NHS up into different directorates, introducing the idea of managerialism within the NHS, and started outsourcing the non-clinical services like cleaning and catering. And they were arguing, well, you don't need a health service to do these in-house because they are not delivering healthcare. So we'll get private companies to do this. And public weren't keeping their eye on the ball. We sort of swallowed this idea. Thatcherism was new. We all, some people were fooled by it and hopeful that the market was miraculously going to do everything better. We know different now, of course. And then we had, in the 1990s, Ken Clarke came along and introduced this purchaser-provider split, setting up GPs as purchasers of care and hospitals as providers of care. Again, it was this phony market philosophy that somehow by giving GPs the control of the purse strings, we could demand a greater service out of our hospital colleagues. The reality was this attracted entrepreneurial GPs who managed to siphon off money into improving their surgeries, fair enough, investing in the capital outlay, but also improving their own financial positions in a lot of cases. And it set up a two-tier NHS. So you had a fund-holding NHS, which was given preferential treatment. And I have experience of this. I was a hospital doctor in the early 90s, and we used to get these letters with big bold stamp on them, a red stamp saying fund holding. Now I went to the nurse who was running the clinic. I said, what does this mean? What do I need to do with this fund holding person? So it doesn't really mean anything. It's just that they've got through to the clinic quicker than a non-fund holding practice. I said, well, my manner's not going to change. I'm going to treat them exactly the same as a non-fund holding practice, but it struck me as perverse. Why are these some GPs getting an advantage? But the real thing about that was a gradual erosion of the culture of it being a collaboration. Everybody was the same. One practice wasn't better than the other, and patients were treated according to their clinical need, not on who happened to be their GP. So the rot was starting there in terms of shaping GPs' view of themselves, no longer as the patient advocate without any prejudice, without any judgment. Now there were more little businessmen looking for business opportunities, and that culture continued, and it's off the scale at the moment. So that took us into the 90s, and then unfortunately, things continued under the Blair-Brown government, despite us being told there were 7 days to save the NHS and all the rest of it. But actually, we as people who believe in the NHS dropped our guard, and Blair and Brown managed to push through a lot of reform, which we are all paying the price of today. And let me just give you a few examples. Number one was Private Finance Initiative, which was a mechanism to saddle the NHS estate with unsustainable debt, which would get bigger and bigger over time, and then be used as an excuse to sell off NHS land and assets. It was a financialization con trick. But how was it sold to us? Well, it was sold to us by Blair saying, well, we need hospitals, we've got Victorian infrastructure, let's use the private sector efficiency again and build all these lovely hospitals. But for every hospital built using PFI debt, not only was it extremely expensive, borrowing from the private sector, but every hospital that it replaced, the new hospital had a third less beds. So you could equate the PFI program as the biggest hospital bed closure program we have ever seen. So it was a very clever ploy to trick us into looking at the shine in the hospitals, but not looking at the finances. The other problem with these PFI hospitals, they were built and designed for the future NHS privatized market. So a lot more individual beds rather than wards. You had these hospital foyers, which looked more like a shopping center, to introduce various commercial outfits to flog their goods to us while we're in and out of the hospital. And the key departments within the hospital were downsized. So the A&Es became smaller. In fact, the space between the beds became smaller, ignoring infection control and actually proving to be a significant problem through the pandemic. So PFI casts a very long, toxic shadow on the NHS to this day, and it continues because we've got a huge debt liability. What else did Tony Blair do? He cemented the toxic top-down management culture within the NHS, giving more and more power to bureaucrats and administrators to keep the medical profession under control. And towards the end of the decade, 2008, 2009, we had a blueprint by management consultants called McKinsey, Quality and Improvement and Productivity, the QIP report, which set out how the NHS assets could be liberated and how it was important to reduce the workforce to get more efficiency out of the workforce. And then that goes into the downskilling agenda. And that was the time we were entering in the post-financial crisis world where the problems raised by the banks, the casino banking culture that had developed, that had sent the whole world into a financial crisis and spiral, was the background for the 2012 Act. And it was that austerity narrative that was used to assault us with that act, which Sandra will tell us about.
Thanks, Bob. Thanks for having me on today, Bonnie. I must say before we start really that I'm a member of Keep Our St Helier Hospital campaign, which includes Keep Our Epsom Hospital campaign, and we are strictly non-party political. And as Bob just said, really, none of the major parties escape blame for what's happened to the NHS up till now. So it's part of my ambition to stop the rot and stop the damage that's been done by all the major parties. And I'm not a member of any political party, so I consider myself impartial in this. The Health and Social Care Act is now being put forward as if the government realised it was a terrible mistake, and they're setting about putting right the mistakes that were made in the 2012 Health and Social Care Act. But that act did three main things, and the first of those things, the first clause was to remove from the Secretary of State for Health the duty to provide us with an NHS. It was the first thing they did. It wasn't accidental, it was intentional and deliberate. And I believe one of the main things they were hoping to achieve by that was so that to break up the NHS, to stop it being under government control, to put it into the hands of, to make it into the biggest quango in the world, actually. And they put in charge of running NHS England, at least, a particular person. I'm not sure whether I should name him or not, but they put in charge of the NHS Simon Stevens. Well, everyone knows who that is. And his previous 10 years, he was working for the biggest private health insurance company in the US. He was the president of global sales, global outreach. Before that, he worked for Tony Blair, advising him on health services. So he's had a foot in several camps, and they made him in charge of the biggest quango in the world. And really, his main job appears to have been to set the NHS up into the position to make privatisation a great deal easier. And now he's done most of that. He divided the country up into 44 areas and told them without it being said in the press, but he told those 44 areas that they had to cut 23 billion from NHS spending. And our area had to cut £1 billion from NHS spending. And they were recommended, and they've taken that on, that they will achieve those cuts by cutting prescriptions, by cutting the sorts of treatments that doctors, GPs are allowed to ask for their patients. And the biggest thing of all is closing A&E, maternity departments, and in some cases, whole hospitals. And in our area, they're talking about downgrading 2 hospitals and cutting 500 general acute beds. Now, this is a massive cut, and it's being done under the instruction of the Simon Stevens, doing the work that the government put him there to do. The other thing he did was put all the purchasing in the hands mainly of the GPs. But as Bob said, the ones that ended up running these systems were mainly the more entrepreneurial GPs. And even at the very start, it was found that about a third of them had conflicts of interest. They had business interests, and they were being allowed to give contracts that were in their own interests. And this has not been properly checked or balanced at all. So the whole system was set up to break the country up into nice little areas, which now I believe the government are going to use this to put private companies in control of whole areas of the country, have total contracted the contract to provide all the health services in those areas, and they're giving themselves permission to award those contracts, not to lots of private companies. Yeah, they are cutting the number of private companies being given private contracts in large areas. They're going to give a contract to one company to run whole areas. So they're talking about major contracts to fewer people. And one of the biggest things they're doing with this reform is to remove the scrutiny and remove the need for competition in allowing these contracts. So in fact, they're giving themselves permission to do what they've done throughout COVID. That's to give massive contracts to single providers for large areas. So this isn't a good thing for the NHS. They're not doing us any favours. They're not repenting their actions. They're carrying on with the plans they've had from the very beginning.
That's really helpful. From what both of you said, then you've laid out a picture where, if you like, the market has taken priority over medicine. And obviously, when you're looking at a market running something, the players in the market's first priority are going to be to their shareholders, not to the quality of their services and so on. Nicholas, did you want to come in there and talk a little bit about the history of what's been going on?
I did. Can you hear me properly from here?
Perfect.
Just checking. Okay. I mean, it occurred to me there's a film director talked about, just as a comparison, somebody's life, the whole life being filmed, 10 different directors editing that would make 10 different films. And I just wanted to talk about basically the same things you both talked about, but it's a slightly different angle, but it's the same things and it all links up. And it's just that looking over this and, reading other people's work about it, there's something that it boils down to that I've been struck with, and that when the internal market legislation in 1990 that Bob spoke about earlier on with the GP fund holding and how that sought to bring in a big business culture and bring an advantage. That was very specifically described by the minister who announced it, Quentin Davis, in Parliament, as modelled on Kaiser Permanente's HMO model in the US, the Health Maintenance Organization, which is another name for, we mentioned this before, but managed care, accountable care, integrated care. You could call it anything you like. You call it potato, but don't get lost in the name, because people do. I mean, it's like we were talking about potato. Well, this potato sounds good. I mean, what's wrong with potato? It's nutritious. Don't get lost in the name, because it's been willfully confused with the idea of integrating public service healthcare with public service social care, which is almost non-existent, for the public benefit. Whereas it boils down to something quite simple. And the guy who came from Kaiser Permanente, the lobbyist, the consultant to Kaiser Permanente, Alan Enthoven, on whose work that original legislation was based, largely, also acknowledged by the minister who introduced it, said this was these were incentives to bring out the self-interest. So that's what Bob was talking about earlier on, and it was very clearly part of the point of it. So what it does, you get a budget between a bunch of providers, and they get rewarded financially for spending less of that on healthcare. And that's what's happening. It's what's been happening. You look on, on YouTube, whatever, King's Fund, you can see Andrew Lansley with the Blair advisor, Chris Ham, speaking to a pilot. Somebody's running one of these pilot projects, 2011, the time of the Health and Social Care Act. And they're talking about that. They're talking about reducing spending on, a series of different aspects of healthcare and bringing in and sharing the rewards, the risks and the rewards. It's exactly that. And this is 2011, the time of the Health and Social Care Act. You also see it, Tamasin Cave of Spinwatch, got the FO, did Freedom of Information requests around the Health and Social Care Act, and the presentations that McKinsey was making to the government involved comparing the new structures with the structures of Kaiser Permanente in the US. And then afterwards, you get Simon Stevens saying, well, what we're going to do is going to bring in accountable care organizations, which is the same thing. Bodies have revolving doors with the private sector organizations that have been actively involved in changing from the NHS model of total provision by the state for healthcare to the model that's used in Medicare that only covers a little bit of care for some people and everyone else is exposed to having to pay or suffer. That's just facts of what's been going on. So yes, the fact that they're saying that they regret it, and they've said that since 2014. No, we're trying to fix the problems with the health and social care. Most MPs in all parties are convinced that this little story is true. And talking of cognitive dissonance, you can see that, you can have MPs from the, Labour and so on talking about, look, those Tories, they're privatising to their mates, blah, blah, blah. And at the same time, they're saying, oh, look, they're doing some really nice integration at the same time. And Einstein said you can have two completely contradictory ideas in one head at the same time. There's an example. Those two things aren't happening. They're the same people doing both. And they're not the way you think they are.
It's a really helpful insight there, Nicholas. There's a hell of a lot to unpack from the contributions all three of you have made. Sandra, did you want to say something else as well?
Yeah, absolutely. In talking about contradictory ideas, we're being told through the media that the government are removing, that they're speaking as if the government are intending to remove contracting out. In fact, what they're intending to remove of the only good thing, as far as I can see, in the Health and Social Care Act 2012, and that was the Section 75, which dictated that although virtually everything had to be put out to public tender so that private companies could do jobs that had been done by the NHS, the only good thing was Section 75 that said that these contracts had to be competitive and they had to be transparent and open to challenge. And the big thing the government want to do about that now is not stop that contracting out, but remove all the transparency and remove the competitive tendering, giving themselves the opportunity to award those contracts to whoever they like, to whoever they choose, with no tendering process and no transparency. So it's a really bad thing, but it's being spun in the media and by the government as if it's a marvellous benefit and that they regret their previous actions. They don't regret them at all. They're just making them worse by law.
Bob, thank you. Did you want to come in there, Bob?
I think it's really important to re-emphasise and summarise what people have just heard. The government could never get away with what they intend to do by being open and direct with us. Right. So they have to cook up a whole series of lies. You have the snake oil salesman from one party or the other come along and say, we've tweaked the ingredients of this snake oil and we've stuck a new label on it. But the snake oil doesn't work for the problem. This is 100% total fabrication and lies and plausible narratives. We keep hearing plausible narratives written for the BBC and co to present to a unsuspecting population. The last thing in the world they expect their government to do in the midst of a pandemic, which we've done so appallingly, is further trash the health service. What rational person, what person with any empathy and humanity could even start to contemplate that the government are doing exactly that? Because we're not led by empathetic human beings. We're led by sociopaths, people promoted beyond their intelligence, just doing the bidding of international corporations, be it with a red rosette or a blue rosette or a yellow rosette. the solution they're presenting is the same. And that's what people need to get their heads around, because, you know, we are all pre-programmed. It's part of the human condition to want to believe our leaders. And we know where that got the Germans in 1930s Germany. We are predisposed to believe leaders with a suit on and a nice smile and a posh accent, but they are lying to us. Every word that comes out of their mouth is spun and cleverly thought out. And we're being hoodwinked into dumping something that treated everybody equally. We got good healthcare, we got good outcomes for the amount of little money we spent, and everybody was covered. We're being somehow not persuaded because no one's telling us, but that is going to be abandoned in favor of a system which is designed to actively avoid sick people.
Yes.
You have a health system which doesn't want to treat sick people, but just wants to extract money for the shareholders and the executives. And that's what politicians have gone along with.
Yeah, I mean, I think, you know, when I heard this announcement and it was hailed as a great piece of news on the BBC, I was immediately suspicious because confirming what you've both said, particularly you, Bob, having campaigned on our local high street and on doorsteps for years on end, warning people that hospitals are going to be taken away from us and that they're privatising the NHS, I got very used to the response, oh, they wouldn't do that. There's no way they'd do that. If you're going to tell a lie, right, make it a big lie. Because no one's going to believe that these things are happening incrementally and by stealth. So when I saw this announcement that there were going to be these reforms, I had a look at the government website, and on it says a few things that really worry me. The first one says we will support recovery from COVID by stripping away unnecessary legislative bureaucracy. Now, what we have seen as being successful during this coronavirus pandemic is actually where the NHS have been trusted to have some input on what's going on. And the people that work, you know, and thank God that they are working so hard and so well in the NHS, the rolling out of the vaccine seems to be working very well. If only we could have, you know, publicly employed staff taking care of our health since they're the specialists and their priority is looking after people. We are one of the proposed 40 so-called new hospitals that are going to be built, and I know that's going to be built with PFI seed money, and that also of course means that hospital will never actually belong to us. We will be paying for it forevermore and never own it. It's like having a mortgage that you pay year on year out, and you renovate the house and you look after the house and you love the house, but it's never going to be yours. It's, you know, it's the rip-off, isn't it, really? So so where do we go from here? You know, obviously we know that these reforms are going to be a real problem, and I mentioned there they spoke about building on the NHS long-term plan. For the uninitiated, what exactly do they mean by the long-term plan, Sandra?
Well, one of the things I think they mean, back in 2015-14, Sir Bruce Keogh, government advisor, put forward the idea that instead of at that time we had something like 225 A&Es in the country, he put forward the proposal that instead of those 225 full A&Es, we should have between 40 and 70 major A&Es, and the rest should be left to serve much smaller needs, much less serious needs, probably urgent care centres. And I thought the number that he chose, between 40 and 70, has turned out to be quite interesting. There's two other factors here where they're using those sorts of numbers. You've got Boris Johnson talking about 40 new hospitals. And as you said, by no means do they actually mean new hospitals, but 40 is coming up there. But also Simon Stevens, when he set up the Sustainability and Transformation Plan, he divided the country up into about 44 areas. Again, similar numbers. This again, I think, links in, and I'm sorry this is a bit complicated, but the whole idea of what Nico was talking about, the HMOs, the ACIs, ICSs, whatever potato you want to call it, it seems to me that it's quite likely that we could end up with about 40 areas under STP, and each one of them being allowed to keep one major A&E, paid for by the government probably. And I fear that the intention could be that they are the only NHS hospitals we're left with, and that the rest is done by private companies. And I think that split would possibly be because A&E is very expensive. You don't make money out of A&E. It's very expensive and very hungry for staff and medicine. So that is not something that private companies would be particularly interested in. I fear where we could be heading in this long-term plan is 40 A&Es in the country, in England, and the rest provided by private healthcare providers under an insurance scheme, where, as Bob says, they give you as little care as possible and they keep the change from whatever they're paid for providing that care. So we could have a skeletal NHS and all the rest of the money-making procedures done by the private industry. I don't know what the rest of you think, but those numbers seem to gel quite nicely to me.
It's a bit of a coincidence, isn't it, that we're talking about 40 in both circumstances.
Yeah.
Another thing that concerns me about this is the rationing of services. I mean, we remember a while back they were talking about postcode lotteries and so on. Another thing we need to consider is if the doctors that decide what healthcare you're going to get are financially benefited from denying healthcare, how often will that happen? I mean, I remember there was a clip in the was it Michael Moore film called Psycho, where a doctor was
Sicko, not Psycho, same thing.
Sicko, thank you. Yeah, Sicko, where a doctor was saying that she had to make a decision to deny someone care that could have saved their lives, and how that weighed on her. You know, she had some scruples and she still felt the need to do it. You know, this is not the sort of pressure our medics need to be under.
That was managed care, which is a synonym for the type of system we're getting now. It's the same system.
So what I've put on screen there, Bonnie, can you see that?
You have a look.
Yeah.
That is an extract of a paragraph from the long-term plan, which the key words are shared saving schemes. So what that means in effect is the introduction of perverse incentives, money, so that doctors or whoever's seeing you has a perverse incentive not to refer you, and the money saved, there will be a slice of the action for the person not referring you. It's not why I came into medicine. And the beauty of the NHS was you could give your honest opinion and do the best for the patient, because your income was separate from your relationship with the patient. Private medicine and these sort of perverse incentives completely destroy that patient relationship, contaminate it, and will decimate the trust that is central to the successful doctor-patient relationship.
Yeah, and I, as a patient, if a doctor told me that I don't need a procedure, I would, under the circumstances that they're trying to bring about, I would then be concerned as to whether the doctor's saying that because I don't need it or because he's not prepared to finance it. I want to take what my doctor tells me as his honest medical opinion, and not have any reference to the costs or the savings involved.
Absolutely. I mean, one of the big problems that's coming about in America, where they have an insurance-based system, which incidentally costs the states a lot more to deliver per person than our NHS costs, because our NHS is the most cost-effective and efficient health service in the world, I understand. What we see in America is a lot of doctors who are covered under people's insurance schemes prescribing and advising procedures and medications that aren't necessarily medically the correct thing, so that they can claim the money back. Again, it's a trust and confidence issue, isn't it, for how we relate with our doctors, and money is the root of all evil. You know, money, we don't want money to make the decision on what we need to keep ourselves healthy.
Well, on that subject, can I bring up this slide? Tell me if I can. So what you see is a headline from the New York Times about a management consultancy called McKinsey, and they have been central to propagandizing for a conversion to the American system for decades. They were first in the NHS in the early 70s. They were also key authors of the 2012 Act. Dido Harding is a former McKinsey alumni, as was her husband, who is the anti-corruption czar, believe it or not. But what McKinsey did, people may not know, but there's a opiate epidemic in America, whereby in the last decade or so, 400,000 to 500,000, that's 500,000 people have died as a result of opiate overdose and addiction. And the company behind it was a pharmaceutical company called Purdue, who went around brainwashing doctors to prescribe their drug OxyContin, and said although this is a heroin-based drug, it's not addictive. And they used various strategies, including employing lap dancers to persuade doctors and giving all sorts of financial incentive for them to prescribe OxyContin. And that's what was the root of the opiate epidemic in America. Now, that not being bad enough, McKinsey thought it was a good idea to go and give management consultancy advice to Purdue Pharma to further increase their profit and to further expand the death toll from the opiate epidemic. These are the people who are the authors of all these NHS reforms. These are the people that our governments, our politicians have put in key positions of power within the NHS. And Dido Harding is not alone. Malcolm Grant, he's also on the NHS England's board. Simon Stevens, we've heard about, is from the United Health, and the America's biggest insurer. So they have more or less colonized the body of the NHS with their business ethos. It's all about the money.
And that's worrying as well when we start thinking about integrated care and the model for integrated care. Of course, there needs to be a connection between the hospitals and social care, shall we say, or care for the older people and so on, because there should be a connection. It should be that if you're elderly and you've been in hospital, perhaps home isn't necessarily for a while at least the best place to be, but we're seeing people having to sell their homes because generally speaking that sort of care is paid for privately. So if we were to bring that into a publicly provided model, that would be a very good move for us, I think, for the general overall health of our nation. But at the moment, while there is so much private interest and action within the healthcare model, the social care model, perhaps what we're going to see here is the opening of a door to a part private funded national health service, and that is a real concern of mine.
Yeah.
Well, if people have long memories, they may be able to if you listen to the song Club Tropicana, they talk about DHSS, Department of Health and Social Security. It used to be integrated.
Yeah, absolutely.
Governments broke it up so they could privatize social services first, and then later on come for the NHS.
Yeah.
So they've been doing it by stealth in parallel. Now this supposed enlightenment to emerge the wholly privatized and means-tested social services, the NHS, well, what better way to introduce means testing for the NHS?
Yeah, absolutely.
At the same time, you have this parallel pressure on immigrants and charges. So you build in an infrastructure within the NHS for a charging system extended to everybody, as Letwin outlined in his Britain's biggest enterprise document.
I think Nico wants to have a word.
Yeah, sorry. I wanted to link a few things. I'll take my mind to link things. You, Sandra, you're talking about any hospital care being expensive and so on. And also, and sort of a side thing. I mean, my background's in language, and there's the expression "a false friend" between two languages. You've got a word that sounds the same but means something different, and like exquisite in English, or if I'm not talking rubbish, exquisito in Portuguese means this more like something disgusting. So it sounds the same, but it's a different meaning. And integrated care doesn't, it's been confused with the idea of social care and health working together. And it does involve groups collaborating about something, but it's not fundamentally about health and social care working together for the public, but it's a different thing. So it's up to us really to find language to distinguish those things. We can, maybe talk about collaboration between a non-existent public social care service and, and the healthcare service, but it's completely theoretical. I mean, people have tried things, and within the context of coming together to get paid to cut services, which is what this integrated care Kaiser system is. You have the idea is constantly being put out that it's about collaboration coming out of silos. They always talk the same language, these people. If you watch their really boring sounding videos, lots of them on YouTube, they're always talking about this stuff. So within the people who are doing this stuff, there may be an idea that that's what it's about, but they know that it's essentially about reducing services because they're in it, and that's what we need to be clarifying. So fundamental element of this, of Kaiser Permanente system is, and if you read the long-term plan, it's full of it, moving care out of hospital.
Yes.
Now, what does that mean? As somebody asked a Labour shadow health secretary in an Nuffield Trust meeting, when you're moving all the care out of hospitals, somebody asked, what's going to happen to the hospitals? Because, your predecessors They showed up at Save Our Hospital campaigns. We're talking about Jeremy Hunt in this case, but Andrew Lansley, David Cameron, who attended the Junior Doctors March in 2007 and said, Labour may have been the party of the NHS before, but it isn't anymore. And he was right. He was right at the time. And because they did this. So there's, again, with Cameron, there was this pretense of trying to reverse the process. Whereas, as soon as he said, he made this speech, I think I may have mentioned, he made this speech at, you can find on C-SPAN 2007 Tory conference, and he's saying people like their district general hospital, they want their children to be born there, they don't want to have to travel hours to get to an A&E, and you get the Conservative Party audience bursting into applause, and it doesn't feel staged, it feels spontaneous, except for the goons on stage, the shadow ministers. And he looks, to me, this is just me, he looks taken aback by that. And he goes on to finish his sentence. And we will fight this until the day of the election. That is not one day more, because that's what they carried on bringing in. So it's constant, yes, keeping care out of hospital, blah, blah, blah. And why? Because hospital care is expensive. Because who cares? You're not looking at the cost if you're providing a public service. That's not what austerity tells us. Austerity tells us we have to reduce costs because they're trying to embed those kind of commercial ideas in people's heads. Tony Benn has this speech. He says, what should the government, about what we should expect from a government, what people want. They want health, they want education, they want employment. And they've turned that around slowly. We used to look at people in the States saying they don't want, public health care because it's a bad thing and laugh. But that's the idea that's coming in. The journalists who ask Jeremy Corbyn, for example, how are you going to pay for it? How are you going to pay for it? When it's something social, when it's bombing another country, it doesn't come up. When it's giving money to Serco, it doesn't come up, because they're trying to turn it around. They're trying to tell us that state's duty is not to give us health, not to give us education, not to give us employment. That's basically the idea. But I digress a little bit. But the whole point of integrated care or managed care or accountable care, this cuts for cash scheme that's been called, is to make everything about what's profitable. You get rid of things like A&Es. So this is really anecdotal, but I was speaking to somebody recently who was doing her nursing studies in the 90s, and she said I think it was her lecturer who spoke with the major government, and she was just saying that from his conversations, they were thinking about 50, the equivalent of major trauma centres, that 50 major acute hospitals for England at the time. So it's the same kind of idea, and they tried to do it. And also because David Cameron's lot joined in, but there was so much revolt against Blair's closures. And Bob mentioned the same sort of parallel figures in terms of beds. And Alison Pollock says for almost every PFI hospital built, 3 hospitals closed. It was the biggest closure program, as she says, as well as what Blair boasts. So, and that's happening now. He's presenting 40 hospitals, an empty glass as a half full one. It's not even, it's probably boiling it down to 40 hospitals, because that's the way they've been going. And I just want to show one quick thing. I'm going to share my screen as well, if I can find it. It's just a headline: GPs being paid to cut patient referrals from 2015. That's managed care, accountable care, integrated care, the Kaiser Permanente system. That's what that is. That's what's been rolling back our healthcare. That's what's closing your hospital.
Wow. Sandra, come in.
Well, I mean, I'm harping now to our local case, but it is a case in point. Where we live now in southwest London, we've got 5 major acute hospitals, and under the reforms brought in by Simon Stevens, who was appointed by the government, they were told they've got to cut £1 billion. So what they're intending to do, instead of having 5 major acute hospitals, their plan is to reduce that to 4 or even 3. And they're achieving that by removing all of the acute services from 2 of those hospitals, Epsom Hospital and St Helier Hospital, removing all the acute services. So we're talking A&E, maternity, intensive care, coronary care, cancer care, emergency surgery, emergency medicine, and urinary care, from 2 major hospitals serving 750,000 people, and in their place, and with 1,050 beds between the 2 hospitals, general acute beds. And their plan, one of Boris's 40 wonderful new hospitals, is to build a very small acute services only unit with 500 fewer general or acute beds. So we're now going to have 500 acute beds for those 750,000 people. It's going to be very small. It's going to be further away from most people. So we're talking longer journey times, and longer journey times means more harm done to patients, more deaths. They're moving it further away from most people. They're intending to move it further away from the most socially deprived areas, further away from economically deprived areas. They're putting it in one of the wealthiest parts of the catchment area. And they're spinning this as a good thing. They're spinning this as an advantage, and we're losing 2 major acute hospitals, and they're going to end up with nursing care beds only, and if we're lucky, a GP or even nurse-led urgent care centre. That is a major cut in all sorts of ways, but it's being spun as if it's something that we should all be glad and grateful for. And one final thing I want to say about our local plan, the Health and Social Care Act cut the amount of, increase the amount that private trusts, that hospital trusts could make from private sources. Used to be 1 or 2%, Bob will know which of those it was. It used to be that a hospital could earn 1 or 2% of its income from private sources. One of the other things, Health and Social Care Act, it increased that from 1 or 2% to 49% of their income from private sources. One of the hospitals that's leading the race on private income is the Royal Marsden, a branch of which is in Sutton, and funnily enough, it's as part of that they're planning to build this single acute facility. It's going to be co-located with the Royal Marsden. Now, the Royal Marsden is pushing that 49% limit, and they have said that they intend to get more income from private sources. And if that means they breach that 49% limit, they will go private. So our only acute facilities, our only A&E, our only maternity, our only intensive care and emergency stuff that we are using in COVID will be co-located with a major cancer hospital. So any future highly infectious people will be co-located with cancer patients with restricted resistance to infectious diseases because of the treatment they're having. It will be half the size, and it will be in a hospital that has threatened to become a private hospital. This is not good news for anybody in our area, but it's not confined to our area. This is happening to other areas all over the country, are facing similar cuts in hospitals, A&Es and maternity services. This is a nationwide problem, and we're being fooled because in each area, people think this is merely a local solution to a local problem. It's a national plan to cut the number of hospitals, A&Es, maternity units, because all those services are risky and expensive, and they don't appeal to the private sector.
Thanks for that, Sandra. Just coming in very quickly, I want to reiterate that this is a plan for the whole of NHS England, which, by the way, is another quango that should not exist. It should be a national health service. And I would just like to make a point. I mean, I proposed motions at Labour Party conference twice recently opposed to the privatisation of our NHS, and they were accepted and passed unanimously. Sorry, Bob, did you want to come in?
Yeah, I just want to give an example of where the government managed to integrate very well. And that was, halfway through the COVID crisis, where they threw money at local councils and nursing homes and issued an instruction to NHS trusts to discharge elderly people back into nursing homes.
Yeah.
What was the consequence? 20 to 25,000 deaths within our nursing home. The government deliberately set off a mass death incident within our nursing homes across the country. There should be some questions as to how did that happen? And I think it points to the complete disempowerment of the medical and nursing profession within the NHS.
Yeah.
Couldn't collectively resist following this instruction. When you're sending potentially infected people into a home with very vulnerable other people, be surprised by the outcome. Sandra touched on the reduction in number of hospitals, but there are other ways to stop you getting to the services you need in a hurry. Most blatant is to close your A&E, so you have to travel further. But now you may have noticed on TV the advertising of 111 first.
Yeah.
Now this is a new barrier to you accessing urgent emergency care.
Yeah.
If develop crushing chest pain and you're thinking a heart attack and you drive or get driven to the local A&E, you will be turned away unless you have been sanctioned by 111 first. So this is a desperate measures they're going to prevent people getting care. And the natural consequence is lots of avoidable death. GPs have more or less been sidelined out of the whole of this. During the pandemic, the 111 service took over screening for sick people. GPs were left twiddling their thumbs. Unfortunately, they fell into the trap of closing up shop, a lot of them, and doing just telemedicine. And I'm hearing from, not my patients, thankfully, but their relatives who are saying it has been near to impossible to get a face-to-face appointment with a doctor. Now, that expansion of telemedicine was in the long-term plan.
Yeah.
Before COVID hit.
Yeah.
The direction of travel, the goals they want to achieve is to drastically reduce public provision, to smash apart the doctor-patient relationship, to destroy continuity of care. So you'll never see the same person twice. No longer, your right to access a doctor as the first point of call, which has existed since 1948, has practically gone. And GPs are sleepwalking into all of this.
Yeah.
Because they've been railroaded into a new contract called a primary care network contract, all part of this integration con. And most of them haven't got a clue. And our union, the British Medical Association, is desperate not to tell them. So that, there's a big waking up process to be done. And I think that's where our hope lies. That's why we're doing this program, is to try and inform people, patients, and professionals. Because look at it this way, the professionals are losing just as much as the patients in this new scenario.
Yeah.
Because we'll be putting corporations in charge, and corporations will want to destroy the terms and conditions of employment of the staff.
Yeah.
And neglect the patients.
Yeah.
So there's a natural alliance there that we need to build.
Yeah,
absolutely. Nicholas, did you have something you wanted to come in on there?
Yeah, if I can show, I know it won't be too long, but there's an example of what Bob was talking about how telecare before COVID, not because of COVID, is what it means, the integration. You'll watch, this is an NHS Foundation Trust that's integrated with Babylon Health, and they're talking about savings, and they're talking about 40% of patients being seen in their own homes, which means they don't actually get to see a doctor in person. This face-to-face care as a sort of bonus thing rather than as a right. Before COVID, we're talking about it was going away, and it's definitely the idea that right is not to come back after COVID. So yeah, that's what Labour MPs think that integration, that's what that nice sounding thing is. It's not integrating health and social care, but with some private sector stuff stuck on. It is essentially about business. And it is essentially anti-NHS.
While we're talking about film clips, I know this is advertising really, but I must recommend that people watch the two films that Bob's been involved with, Sell Off and The Great NHS Heist. There is no better way to spend a few hours if you watch on the national thing. And on the local thing, I would ask people to have a look at the KOSHH website and Facebook pages, because they'll get a lot of information there on our local fight. So you've got your homework, folks, for the next few days.
Yeah, I'd also recommend that people that live across the whole length and breadth of England, or the area covered by NHS England, take a look on social media and see what campaigns there are to support their local hospitals, because the same fight is happening right across the country. And I'd urge everyone to get yourself informed and get involved in the campaigns.
Yeah, I was wondering, something I mentioned before, but you're talking about MPs standing up against local closures. Now, I have to say, if an MP wants to show themselves as, or even to actually stand against the local A&E closure, there's no way that they shouldn't be allowed to get away, or maybe they don't understand it. They shouldn't be allowed not to understand that it's no good saying you defend your local A&E and then supporting the legislation that is closing the A&Es, which is what the long-term plan has been doing. And what the legislation that is there to rubber stamp the law had a link somewhere, which you probably won't find. Oh yes, here it is. It's just a headline when Bruce Keogh's A&E closures program that the Telegraph is talking about here, that bastion of communism. It's the actual policy. It's just been invisibilized. It's not talked about, and that's Labour's fault. I'm saying it, I have to say it. It's Labour's fault for not bringing it up. And the reason Labour didn't bring it up is because Labour agrees with this, and because these have been Labour policies. Now, we had a short time with Jeremy Corbyn as leader and with Diane Abbott as Shadow Health Secretary when she was calling out the restructuring for profit, as you know, she quoted the NHS England director, Michael McDonnell, who replaced Simon Stevens as Blair's advisor. There's a constant revolving door with private sector and the Blairites and the Tories. And she quotes him saying that that restructuring would be an enormous opportunity for the private sector. That disappeared afterwards when John Ashworth came in, and he was reported as supporting sustainability and transformation plans, but with more money. Do we want more money for closures? Do we want more money to reward those who are making the closures? I don't. We need to be clear what's what, who's doing what, where it's coming from. If you want to defend the NEs, you have to oppose the legislation.
I couldn't agree with you more there, Nicholas. Bob, did you want to come in there?
Yeah, I just want to say about the money thing. So it will be very easy to trick people into the line that the economy is struggling and we must do austerity 2.0. We've got to remember that the system they're proposing for the NHS on an individual basis will be more than twice as expensive. The way it will work as we drift further into the hands of the insurance industry is you will have a pot of money that comes from the state. That will be, let's say, your NHS budget, but that NHS budget will buy you very little. And in order to restore what no longer exists to be purchased with your NHS budget, you will either do without, you'll use up your savings when you need it, or you take out private insurance. And if you add the total cost of your inadequate NHS budget and your private insurance to the individual, if you add up their taxation and now their insurance premiums, it will be a doubling of cost to the individual. So it's not saving the individual anything. And the nation, it will be doubling the cost to all of us. And at the same time, it cause a leaching out in terms of the bureaucracy and the profits for these corporations, equivalent to the US, which is $1 in every 3 goes out in bureaucracy and profit. It's not about being efficient and it's not about saving money. And if people are still not sure about how far down the line we are, let me just show this very recent slide, which is a headline about how in London, 49 GP practices looking after 370,000 patients have recently been taken over by a subsidiary of an American insurance company. 370,000 patients. And my GP colleagues who are unwittingly going along with the creation of PCNs, well, this is what will happen to a PCN. A PCN will eventually be taken over by a private company, and then all GPs will no longer have clinical autonomy and independence, which they enjoy so a little bit at the moment. We will be employees of a PCN headed up by private insurance companies and American hospital chains.
Can you explain what a PCN is, please, Bob?
Yeah, so PCN is a primary care network, which is supposedly, it's a merging of all GP practices into a big group, and it also fits into these integrated care systems. It forms a foundation. It's a way of collecting together the budgets and the patient list. And that's what it will be based on, what's called population health. So GPs are being tricked into handing over their list to a PCN, but with the list goes the patient's budget. And it's all about grabbing hold of the budget control.
And the patient records too, I presume, Bob?
Yeah, well, that's a whole nother minefield, what they're doing with the patient record.
This model is deeply concerning, particularly if you look at PCNs, or GP practices that happen to be in areas of high deprivation or areas where there is, for instance, a large proportion of people from Black and ethnic minorities, because there will be specific health concerns. And once those budgets for those people have been spent, there's none left for the next person who needs the help. This is a problem. When you're running health as a business and not as a service, the priorities are messed up.
The way it will work is you will see a healthcare professional, likely not a doctor, who, if you need referral, will use a computer system which will direct it to a referral center, and then you'll get a notification whether that referral is accepted or not. So in a way, you can offload the guilt for the health professional by basically saying the computer says no.
Yeah.
You've automated the process of denying care.
I think this is already happening. Correct me if I'm wrong, Bob, but I understood this was already happening in that if your doctor refers you for a treatment, in most practices, that gets put up to a referral panel run by private companies, And people don't realise that when they get a phone call saying, oh, your doctor says you need a particular treatment, and you might have to wait 3 or 4 months for that. But if you care to go to this clinic, which happens to be a private clinic, we can get you in much more quickly. And people don't realise that they're already being moved, funneled into private providers rather than the hospital appointment that a doctor originally might have intended them to have.
Yeah, so what you're describing are patient referral management centres.
Yeah.
And at the moment, they're really like traffic control,
Yeah.
directing people predominantly, if they're low risk and they've got an easy procedure, a profitable procedure,
yeah,
be hived off by the private sector. If you're a complicated, high risk patient, you'll stay with the NHS. Thank you very much. But that traffic warden system will be changed to a eligibility and entitlement denial system. So it's already been normalized. Whenever they introduce a toxic policy, it's benign for a few years. Everything gets through. Gradually, the screw starts to tighten, and then it becomes normalized within the GP. They stop resisting. It's psychology. You do things by death by 1,000 blows, So we are all used to the occasional referral being bounced back, but now we'll be getting used to the care being denied altogether. And by the way, keep quiet because you'll get a percentage.
And another of those problems is the possible disparity for treatment for people who are disabled or with long-term conditions as well, because somewhere on an algorithm, they'll show up as a person with lots of other problems anyway, and it might be decided that they wouldn't recover best from that treatment.
So yeah, I can give you an example. A recent patient of mine, elderly lady who had been seen at the hospital. I think she had a fall, was sent back home. I went to see her. She wasn't doing very well. The mobility was poor. But with the current pandemic, the last place, given the amount of in-hospital infection, I think is 35,000 or so. The last place I wanted to send her was back into the hospital. So I called out the local rapid response team, which is supposed to be occupational therapists, physiotherapists, social work, all together in this lovely community team. And what they did was override my decision to try and manage her at home, sent her in. She went into hospital, caught COVID and died. So my clinical experience of 20 years balancing up the risks and benefits was overridden by people who knows what qualifications they had. So the GP is getting gradually sidelined. And to be honest, I think in a lot of people's minds is, as long as they don't have any responsibility to bear, they can live with it.
Yeah.
What also happened was last year or the year before, our fees for medical indemnity were suddenly subsidized by the taxpayer. So we went from paying £10,000 indemnity next to nothing. Psychological level, that tells you something. That tells you, don't worry, you're no longer on the hook for when things go wrong. Then we had a mandate from the BMA's ethics committee at the start of the pandemic, which was subtly telling medics to do not try and hold patient care up to your previous ethical standards. You need to water them down to suit the current circumstance.
Wow.
All this nudging going on. And I'm afraid most of my colleagues have become numb to it. They've lost the capacity to critically think, maybe because they're overwhelmed with work.
Yeah.
And, they're emotionally and compassionately, they're fatigued. They're struggling to cope. And maybe they think it's a fight they can never win. But that's how you lose.
Absolutely. Look, there's been so much information given out there, and loads of tips and lots of education for people who haven't been aware of all these things that have been going on for so long. But we're coming to the end of our program now, so I just wanted to give each of you an opportunity to wrap up before we end the program. Which of you would like to go first?
I'll
go on then. Go, Bob.
The biggest thing patients can do is demand their right to see a doctor, which has been there since 1948, and try and actively sabotage the downskilling of primary care.
Okay, I would like to say, if you're concerned about your NHS, write to your MP, write to your councillors, write to your local mayor if you have one in a political position. Consider what's being done to the NHS when these elections come up, and vote accordingly. Because for me, the NHS is one of the main concerns for most of us. Education's wonderful. All sorts of other things are wonderful. But if you lose your health or you lose your life, you have nothing. So fight for your NHS, get yourself informed, watch Bob's videos, have a look at our Facebook pages, get informed, and do what you can to put pressure on those with the power to stop these cuts and fight for your NHS.
Thank you. Yeah, I couldn't wrap it up better than that, actually. Hopefully people watching this would have been enlightened in a few ways and encouraged. Please do take a look at the Sell-Off and The Great NHS Heist, both of Bob's films. And once you've done that, please make sure that you take this information to your neighbours, your friends, your relatives, everyone around you, and get yourself involved in any local campaigns to protect the NHS. And if there isn't a local campaign to protect your NHS service and hospital,